Good morning, good afternoon, everyone, and welcome to today's Community of Practice session. My name is Danny Hansler. I'm with Growth Partners, and I'm going to be your tech producer for today. We're so glad you could join us for this important conversation. As you can see the title on the presentation there, Compassionate Conversations with People Who Use Substances. Facilitated by the New Hampshire Department of Health and Human Services, the Foundation for Healthy Communities, and Growth Partners as well. We're grateful to these partners for making this space possible. Right before we begin, we want to make sure we go over a few housekeeping items. First of all, we're recording today's meeting, so just keep that in mind. We're going to make this recording available at our site. We're going to mention that at the end. And make sure that you are on mute unless you're participating on the program. If you're having internet issues, try turning off your video. That makes it a little bit better and to help things run smoothly. We'd love to hear from you, and we'd love for you to engage using the Zoom tools. You're going to see the reaction buttons at the bottom of the meeting there. Use the chat to share general comments or resources or questions for our speaker today. And with that, we are going to continue. And we're going to hand things off to Dan Andrews, who is going to kick things off and introduce our speaker for today. Thank you.
Thank you very much, Danny. It is my incredible pleasure to introduce my friend and one of my heroes in the healthcare field, Jason Lucy. Jason is a nurse, an educator, an advocate, and somebody whose passion providing compassionate care, particularly to those who use substances, is the defining feature of his entire life. He holds a doctor of nursing practice degree. He's a family nurse practitioner. He practices actively in urgent care settings in Dover, New Hampshire. He is also a faculty member at the MGH Institute of Health Professions in Boston, where he received their Award for Excellence in Teaching in 2018. Jason has been one of the pioneers in this field, which was our conversation before the meeting began. For most of the past decade plus, he has been working to advocate for evidence-based practices for persons who use substances. For healthcare, he is one of the founding members of the New Hampshire Harm Reduction Coalition. And as a member of that board, I am so happy that he continues to avail us of his time, expertise, and incredible passion.
Just COP, what's up?
He has also worked in the legislative field as the state has passed or in-service legislation. And today he is joining us to talk about a set of objectives that is as ambitious as any semester-long course I've taken, but talking about substance use as a continuum. We're going to talk about several myths about people who use substances, reframe our language and terminology, and discuss screening, brief intervention, referral to treatment, and motivational interviewing, and then talk about some specific harm reduction interventions that can be offered to improve the experience and improve the safety and lives of the people who we are dedicated to treating. Jason, it's such a pleasure to welcome you to this forum and this community of practice.
Well, thank you so much, Dan. That's a really wonderful introduction. I'm not sure I deserve all that. I really appreciate all the work that you have done as well, and all of my colleagues on the meeting today. Melissa and I go way back, and actually was really, even though she'll deny this, she was influential in striking my passion to be involved in this at beyond the patient level and into the policy arena. So it's really great to be invited to be with you. I hope that some of what I say and what we discussed today is helpful to you in some way. It may be for many of you who may be hyper developed in this arena like myself, it may be stuff you've heard before, but I think it's always interesting to talk about and hear from others and grab little pearls and bits and pieces of learning to bring into our own practices and lives. So I do want to start with just telling you a little bit about my own story. I think that we can advance to that slide, my own story. So as Dan said, I'm a nurse practitioner. I kind of came of age in 2001 when I graduated with my nurse practitioner degree and began working in emergency room settings. And it wasn't too long in those days where I became aware of something going on with opioids, right? I was basically learning how to be a clinician as all of those charts that we see related to opioid deaths and overdoses and prescription opioids, et cetera, were skyrocketing. And so my practice became, I never once envisioned that I would become sort of an expert in this field. I had no real prior interest in it. But what happened was I had a lot of patients who came in to see me and needed my help. And quite honestly, I had no idea what I was doing. And you know, I was looking back and thinking about my curriculum, and I honestly probably had about one case study about alcoholism, and you know, that was it. You know, nobody ever told me that people also like to use other substances and could become addicted to other substances, and we just had I had no tools. So I had to do a lot of self-learning, and I kind of backed into a lot of the science of what we know about addiction and substance use disorder. And what I've realized over the years is, as much learning as I've done, I actually think maybe I've had an equivalent amount, if not more, unlearning to do. And I think that is something sometimes harder than learning, right? Is letting go of some of the things that were just really ingrained in my mind and in my brain and in my actions. And as I prepared this talk today, I was going back through lots of old files, and there are some cringeworthy moments and slides in my own life, and I'm so glad that I've sort of opened myself up to learning about and unlearning myths, stigmatized opinions about people who use substances, and kind of come back to really what I got into this business for, which was helping people and the humanistic kind of nature of healthcare. And I know that probably to a person who is involved in healthcare, that's the reason they got into it. And so I've been really pleased with the journey I've had, and I invite you to sort of let go, open yourself up to unlearning. Next slide. We already went over those objectives, so we can continue on to the next slide. We're going to start by talking about this sort of pictorial graphic, which simplifies a really complex issue, right? This slide is called the continuum of substance use, and you can think about all substances here, right? This is sort of like the sort of my distillation of the science of how humans use psychoactive substances, and you can choose any substance. You know, right now my substance of choice in my life is caffeine, and sometimes I fall on the right side of this spectrum here. You know, I still have an afternoon cup of coffee even when I'm palpitating, right? But there's practically no human individual who does not use any substance, right? And then as we get into more of the sort of potentially problematic substances like alcohol, nicotine, and other substances like opioids, which some of which have been deemed illegal. But the distinction between illegal and legal substances is not all that scientific, right? You can still use legal substances in a chaotic manner, much like you can use illegal substances. So I think that's one of the things I've had to unlearn, is to sort of separate out the legality from the why people use substances and how, right? And what you can see on the right side of the spectrum, what we found over time is that people who tend to use substances in a regular, heavy, or chaotic manner are often seeking refuge from something else, right? They're either self-treating, or they're in such a predicament within society that there is really that really substance use is their only refuge from pain. And I think that really is an important concept to working with people with substances, is you have to peel back the layers, kind of block out which substances they're using and how, and just focus on the individual. Try to get under that umbrella and find out who the person is. So that real simplified version, but also if we click the next graphic, this all happens in the setting of, actually, can we go back one slide? There should be a graphic that overlies this same. If you just click one more time, it should lay that drug set. Oh no, I guess it doesn't work. That's okay. So imagine that the person is what's called the set. Drug use happens in the context of everything, right? And I think that's where another thing I've learned and unlearned over the years is that focusing on just the person who uses substances is an incomplete way of looking at the phenomenon of drug use, right? Every person is acting within a context, and in the setting of drug use, many people are acting within the context of policies that stigmatize or criminalize them, and that affects the harms and their outcomes, right? So this pictograph that you're seeing right now is called drug set and setting, and many of us in the harm reduction community go way back to this Dr. Zinberg's book in the 1980s that kind of solidified this concept. The set, you can think of the person and everything about that individual that may dictate how they experience a substance, right? The setting is everything about the environment, and the drug is everything about the drug itself. So obviously there's many variables that come into play. Imagine, if you will, that we take a couple of examples, right? Let's talk about a set. Maybe I'll use myself an example. A white, fairly healthy male who, in a setting, goes into a bar and uses a drug known as alcohol that is regulated, pure, and relatively safe if I don't drink too much of it. The harms of that whole interaction are very different than perhaps a different set, right? Imagine another set, another person who may be a person of color or a person who is unhoused in a different setting, right? On the streets, in an encampment, using a drug that is not regulated, unsafe, tainted with fentanyl, and they have no clean water to inject it with. So obviously the harms in that situation are very, very different. And thus our interactions with that whole phenomenon need to be different, right? And there's many, many ways that we as healthcare providers can intervene, not just on the set, but on perhaps the setting and the drug. So that gets into the whole policy arena of how we as a society deal with drugs and their harms, right? And I could go on about that, but we can jump to the next slide and continue with the presentation here. So all this to say that drug use and the phenomenon of substance use really is best managed as just another chronic health condition. And I do share with people that I have type 1 diabetes, and when I engage with my care team, I may have moments in time where my use is less controlled, sort of the top left of that double-edged arrow there. And when that happens, my care team works with me to tweak a little bit of here, maybe add a little bit of medicine, change my behavior a little bit, maybe a little bit of both, and try to get me to sort of get more well-controlled. The same concept applies to people who use substances. And in the world of harm reduction, we actually look at any steps towards decreased risks as steps in the right direction. So you may take somebody who is using injectable substances and set a very stepwise goal to, use a sterile syringe every time they inject. And that might be an improvement towards better health for that person. And that is great. That's something to be celebrated. We often, in the world of substance use, especially illegal substance use, we have this really imperfect and impractical expectation that somebody just stops using. And it's just we're going to beat our heads against the wall if we continue to think that way. I think things have gotten a little bit better in this arena in my career. So I don't think everything works this way, but I think our systems are still set up that way in a lot of ways. And then I circled in red here the use of medications, because as a prescriber as somebody who is scientific and I just want to decrease overdose deaths and keep people alive so that they can continue to live life they want the way they want to, and be part of families and be people's loved ones. Like, I really think that we have to get rid of this stigma towards pharmacotherapy in substance use disorder. Again, we've come a long way in that area, and maybe I'm preaching to the choir here since you all are engaged in substance use treatment and prevention. But I don't think that the general population of healthcare providers have yet adopted that approach. And it's really important because the scientific data on lives saved by medications is just overwhelming. Next slide says some of the same things in a slightly different way. We can move on to that. Sometimes I'll engage with people and there'll still be this kind of concept that substance use is a choice, right? And that behavioral change is the only thing that's going to be able to take care of it, right? But if you compare substance use disorder with other health conditions like high blood pressure, type 2 diabetes, and lung cancer, all of these things, the cause of those illnesses are all variable, right? Sometimes there's genetic variants that predispose somebody to those conditions. There are sometimes behaviors that cause things like lung cancer, but also you can get lung cancer without smoking too. My mother-in-law was one of those people, right? And for all of those things, within our Western medicine treatment approach, we have scientifically based treatments called medications that are our number one go-to. And that's where we need to get to for substance use disorder, for those substance use disorders that have proven medical treatments. So I'm really happy about the legislation and policy changes around buprenorphine. My own doctoral project was to implement buprenorphine in the Wentworth Douglas Hospital emergency room, and that's gotten a whole lot easier. My project was about getting people waivered. Now we don't have to worry about that, so it's getting a lot easier, and that's a really, really positive thing. I also like to remind people that there are people, I'm sure if you think of it closely, there are people in your own life, I can think of one or two in my own life, who have one of these conditions like high blood pressure, type 2 diabetes, and they don't really engage in their treatment. They don't not eat sugary foods. They don't diet as much as they should. They don't exercise as much as they should. And yet I still love them. I still take care of them. I still engage with them. And in the past and true to this day, many times people who use drugs and don't necessarily engage in all the treatments that we want to engage in them, they are highly, highly shunned, and if not kicked out of treatment or kicked out of our hospitals. And that's it's again just impractical, unscientific, and cruel. And so I just included the bottom lines on this slide, that people who don't actively engage or adhere to treatment still deserve compassion, still deserve ongoing health services. And that's largely where harm reduction can be your friend. And we'll talk more about that at the end of our presentation today. Next slide. Now it's time to engage a little bit. We're gonna move on to the next objective of our talk here today, and we're gonna launch some poll questions and have you answer them. And there's true/false questions. So let's go ahead and launch the poll. So the first one is, some people who use opioids have Narcan parties where they take opioids and revive one another only to take more drugs and get high immediately after being revived. Second one is, powdered fentanyl is so potent that it can be absorbed through the skin or aerosolized and cause you to overdose if you encounter even a little bit of it. Third is, bath salts caused a person to try to eat the face off of another person. And fourth is, children born to mothers who used crack cocaine while pregnant, i.e. crack babies, exhibit long-term brain and social emotional deficits. And then lastly, methamphetamine causes people's teeth decay. Please fill out your answers and submit whether or not you think those are true, false, and we'll share the results and see what happens. So Danny, I think, will publish the poll results when they're done.
Yeah, we're still at 55% participation. Give a few more seconds.
Sure. Thanks, Danny. It's okay. You're not going to be graded on this. You can just choose your response as best you can. Oh, you don't have a way to choose a response. Oh, I'm sorry, Lisa. All right. Okay, so here's the results. I love that, I've given this talk and this true false questions to other audiences, so I can tell I'm within my I'm with my choir here today, because you guys have done better than other audiences. So so the answers that you can argue with me about this after you read the articles that I give you to support my claims, but I believe all the answers to these are false. So I'm so glad that that you all are in the know as well. Narcan, we can advance to the next. So let's see, the one that answered, there was a majority of people who said true to the powdered fentanyl. So I'll explain a little bit why that is also false. Pretty good percentage also said true to methamphetamine, and I think that's highly debatable. So I'll say more on our next slide. Thanks for sharing those poll results, Danny, and we can advance to the next slide of the presentation. So I'll let you do a little reading after the presentation today to see if you agree with me, but I've included some what I think are really reputable sources and articles about why all of those claims in the true false questions I believe are mythical, right? Narcan parties are actually not a thing. It's become an urban legend, and there's a great article I linked to there that talk about how urban legends actually really it's a normal phenomenon, right? We create urban legends as a way of kind of like dealing with a fearful situation, but unfortunately they do nothing but actually highly stigmatize and potentially influence care of people who happen to use substances, right? If we're scared about Narcan or have a negative idea about Narcan, I really feel the only result that will come from that is more overdose deaths, right? The second myth there about powdered fentanyl being so dangerous that even a little bit that you touch or it can be aerosolized is actually just not true. Many scientists have studied this, and the only fentanyl that can really absorb through the skin is a highly manufactured fentanyl patch that's used in like cancer care and pain care. And the powdered fentanyl that people may use to dissolve and inject or inhale is not absorbable through your skin. It would be very, very strange for that to happen. You'd have to bathe in it, and powdered fentanyl does not aerosolize as easily as you might think. So although fentanyl is clearly potent and dangerous, the myth of it being so potent that you have to have a hazmat suit on to be around it, what does that do? It only potentially makes EMS and first responders fearful of approaching somebody who might be overdosed on fentanyl, right? It's a really dangerous concept, and it's been debunked many times over. And the fact that lots of people still think it's true is really troubling to me, because we don't hear enough about this claim was made, but the truth is it's not that dangerous, right? I worry about the people who have died of overdoses because perhaps EMS has been too fearful to walk into a room where fentanyl is around. And that's terrible for everybody, EMS providers and first responders included. Bath salts, again, none of this is to say that drugs can't be dangerous. Does that make sense? I know drugs can be dangerous, but over sensationalized and over dramatized and mythical thoughts, especially about illegal drugs, do nothing but continue to damage the people who happen to use them, right? The idea that bath salts can create cannibalism is really entrenched in our society still. And the fact is, the person that was engaged in that terrible event in Florida never had bath salts in their system. They probably had other substances and a combination of other health factors like mental illness that played a role in that whole terrible event. But the enduring idea that bath salts are so dangerous that they created that event actually really potentially injures the people who might continue to use bath salts, right? We continue to isolate and marginalize and stigmatize and criminalize people who are in that situation, that set and that setting, right? And then the really interesting, and again, these are things that I unlearned myself along the way, right? Crack babies in the 80s, again, we had reason to be concerned about crack, right? You know, it's potentially dangerous, it's harmful, but the idea that crack babies would be this huge burden to society, that created this fearful response, including policies like, you know, harsh criminal penalties for crack cocaine possession and use. It created this whole, you know, what do I want to say, generation of highly stigmatized and mostly communities of color that were harmed by that policy response, right? When it turns out that years later now, we realize that the children that were born to moms who used crack cocaine actually did not have as drastic social emotional deficits as everyone thought. So again, I think what I've learned over the years is to take sensationalized media reports about substance use with a huge pound of salt. And when I'm dealing with patients who might use substances like this that are in the media, to kind of put that aside and just think about the science. Who's my set? How are they using? What kind of substance are they using? How dangerous is it? Are there any things I can do to kind of alter and make things a little bit safer, and just treat that person as a human being and not some kind of sensationalized villain on the cover of Time. The last, methamphetamine, and I will admit that methamphetamine or amphetamines may actually have a drying effect within the mouth, but one of my heroes in this world, Carl Hart, makes a really great argument that Adderall does the same thing, right? But we don't have the hundreds of thousands, if not millions of people who are taking Adderall, which is essentially the same chemical ingredient as methamphetamine. They don't have teeth rotting out of their mouth, right? It is the setting, and the social context that creates dental decay in methamphetamine users. And probably more than the drug effect, it is the social setting and the lack of access to healthcare, lack of access to housing that results in, you know, severe dental decay. So again, it's overblown, it's sensationalized, and it does nothing except continue to villainize and criminalize the people who are under that umbrella of substance use. All right, so my takeaway there is be suspicious about media reports about how drugs are portrayed, right? Make your own judgments, leave space for unlearning, and approach people with kindness and compassion. We can move on to the next. Thanks. Along the same lines, this may be repetitive to you since you all are my choir here, but we know that research shows that language and stigma matters, and this is not just a PC thing. It's not political correctness. It actually creates negative outcomes, as as the Troy in the chat here says that, ideas about powdered fentanyl have actually, have laws and policy results stemming from this myth, right? Which actually ends up in harming people. Same thing about language, right? The great John Kelly article in this bullet on your screen here. John Kelly, a researcher out of MGH, took a group of people in the know, treatment providers, clinicians, and he separated them into two groups. And he said, one group, you're going to read a story about a person who was deemed a substance abuser. The second group of clinicians is going to read a story about the same exact person, and they're just going to refer to them as a person with substance use disorder. And then the results were pretty stark. People who took care of the substance abuser were less likely to refer that person to treatment and harbored kind of personal feelings of culpability and had sort of punitive attitudes towards that patient. And people who took care of a person with substance use disorder were more likely to refer that person to treatment and were generally more compassionate towards that person. So you can see just from that very simple, elegant study that just that term, referring to a person as a substance abuser, is more likely to result in negative healthcare outcomes. I include a link at the bottom here. If you've never seen it before, you should check it out. It's called the Addictionary, and it really goes through a lot of our lexicon and helps us learn how to speak better about people who use substances. Next slide. Yes, Peter. Yeah, similarly, terms like denial are stigmatizing. Yeah, absolutely. The Addictionary is great. You can look through it and sort of refresh. And this is where I do a lot of my unlearning. I kind of realize that, oh, I shouldn't use that term in slides, and I shouldn't use that term as I talk. And it takes some work on our part to really get better at this. This slide is just a summation of two different research. It wouldn't allow us to click the link. Can it be put into the chat? Yeah, I'm sorry, Priscilla. We're going to share the entire set of slides with you. I'm not sure if we'll be able to do the links right now, but I know that the plan is to share the slides with you. I apologize. So this slide is inpatient care of people who use drugs. If many of you are in the hospital setting, these two things for me were moments of like, wow, that's something we can do differently. On the left, there was a small study of people who injected drugs who were treated for soft tissue infection and abscesses. And if you've ever seen an injection-related abscess, you know how painful they can be, how terrible they are. And these numbers just make me sick to my stomach still as I read them. 43% of people with a soft tissue infection waited 2 weeks to seek care. 59% of people who with those terrible infections left the hospital early in the study. 40% tried to just self-treat with antibiotics, and 57% attempted their own drainage of these horrible abscesses that deserve, like, if not surgical sedation, at least local anesthesia for incision and drainage. I can't even imagine somebody having to try to self-drain one of these abscesses. And the reasons that all of these people reported for delaying care or for leaving the hospital were they felt judged, they felt mistreated, they were in withdrawal from their substance, and they had uncontrolled pain despite being in a hospital where we have lots of interventions to control pain. And so those things are, when I speak with my nursing students about judgment, mistreatment, withdrawal, and uncontrolled pain, all of those things are easily treated by a good nurse or any other healthcare provider. All of them. The second study on the right was a little bit later, 2020. One of the authors is Sarah Wakeman, who is a wonderful resource out of Mass General Hospital. If you haven't ever heard her talk or read her articles, she's a force of nature. Again, they found similar things. People felt that their withdrawal was undertreated. They continued to have ongoing craving to use drugs. They had uncontrolled pain. They felt highly stigmatized and discriminated by hospital staff. And they had hospital restrictions. It feels like a prison, not a hospital. And the summary of that particular article is that we need further support for inpatient addiction treatment. Those things have gotten better, I think. Down where the hospital I'm affiliated with at Mass General has an amazing inpatient addiction team. I know other hospitals are sort of following their lead, although I don't know about all of our community hospitals in New Hampshire and whether or not, having substance use and addiction experts on the floors to, help with methadone, buprenorphine, pain control, those kinds of things. I'd love to see that as the standard. I'm not sure. Dan, you can probably speak more to whether or not that's the case yet in New Hampshire, but Dr. John Kelly presented. Nice. Thanks. Next slide. How are we doing on time? 12:36. Okay. All right. The next objective that we wanted to cover today, and Dan joked about how I have too many objectives. I apologize if I'm talking too fast and overwhelming you. I hope that you can digest these slides after the fact. I know there's a lot of words on them, so my apologies about that. Screening, brief intervention, referral to treatment. I'm sure amongst this group of people, you're all familiar with it. I was just going to review the actual steps of it. And also, I just want to, as I reflected on how much is here, I want to caution you, if this is like your first exposure to it, or you haven't really, done much of it, I want you to know that it's okay to take little pieces of this and just start experimenting with it, right? You don't have to do it all at once, right? I think my summary of SBIRT is just go ahead and be curious about substance use. Be ready to ask some questions and express some kindness and tell people that you care about them and you want to learn more about them, and be ready to talk. And some of this will just come naturally. As Dan and I were planning for this talk, I told him a story about a patient I had once years and years ago. This is probably before I met Melissa. And he was a person who was kind of a quote unquote frequent flyer in our emergency room. And even before I got to see them, there was all this scuttlebutt in the ER. It's like, this guy's here again. And, I think the registration people figured out he was using a fake name, and, he'd already been here before with a different name, and he's gotten a lot of Percocet from us and blah, blah, blah. And he's here for back pain again. And so there's all this just systemic kind of noise. And so I went in to see the guy, and I saw him, and, I did my thing. I just basically listened to his history, did a physical exam, and diagnosed him with a low back strain. And, at that point I was I'm not, at that point I was already I'm not giving Percocet for every low back strain. I'm just going to give you some, ibuprofen and a muscle relaxant. But I had this kind of sinking feeling as I sort of finished. And he was on edge too. He was just he knew there was a lot of scuttlebutt, and he wanted to leave. He wanted to jet. And I was like, all right, I can just write this guy my Flexeril and get him out of here. And I'm standing at the counter and I'm thinking about it. I'm just but that doesn't feel right. This guy's here with some other emergency that's kind of under the surface. And so I went back in the room with one of my nurses, and I just said, listen, man, I'm really worried about you. I'm concerned. What's going on? And he told me everything. So I just screened him, and I had a brief intervention by just saying, I'm concerned about you. And in this case, glorious moment, he let it all out because I was willing to receive it. And then I helped him get into treatment, and he wanted it. And that doesn't happen every time you screen somebody, but it can happen. And after that experience, a really, really cool thing happened. Many months later, I was at a park with my own kid playing on a playground. And who do I see? This guy with his kid and his family. And I don't usually reach out to people that I see in the community if I've seen them in a HIPAA and protected environment. But he came up to me and he was just like, dude, thank you so much. Here's my life. I'm doing well. I'm in recovery. And I was like, oh, wow. that one moment, that where I said, you know what, I'm going to go back in that room instead of just letting him go away. I might have had something to do with saving his life. I don't want to take all the credit, right? Because he did all the work. But I had a role in that. And so after that happened, I emailed all my providers, my colleagues, and I said, this is what happened to me today. Like, I feel like, yeah, I'm only the urgent care provider, but I might have just had as much of an effect as helping that guy with a STEMI just by being willing to talk to him about something that people don't like to talk about. So that, that was very early on in my career and all of this, but I still keep coming back to it. And really what I was doing there is SBIRT. I didn't know it, but I asked him if he used substances. I asked him if they were causing him problems in his life. I told him that I cared about him and that maybe there was something we could do to help him. And then he was ready for treatment, so I gave him the referral. So much we can do. So that's what SBIRT is. We can jump to the next slide. You can code for SBIRT if that's all we care about is money. We can get reimbursed for it. The beautiful thing about SBIRT is that it is designed to be used for everybody. Large numbers of us use substances with relative low risk. So 71% are, you're going to screen, and then you're going to ask how risky they use. You find out that they don't have all that much risk, and you don't have to intervene. About a quarter of the people will have some harmful and risky use happening, and that's where we talk about prevention. That's where we can intervene. We can say, hey, did you know that drinking more than 4 drinks in a sitting scientifically is, increases your risk of alcohol-related adverse health effects? Did you know that having more than 7 drinks a week, 14 drinks a week, can increase your risk and actually, impact things like hypertension and all these other health effects. Like if we're willing to have those conversations, we might get to people before they develop substance use disorder, right? And we can really make a dent in the negative health outcomes. And then there's going to be that smaller percentage of people at the top of the pyramid who actually already have dependent use, risky, harmful substance use disorder. But the beautiful thing is now we have lots of interventions, right? Including medications that you can start in any venue if people are ready for them. All right, next slide. This slide, we'll whip through this one. I use the DSM-5 definition of substance use disorder, and it's kind of big. We can keep clicking right through every part of this slide. This slide is way too wordy, but just to remind you, there is a definition of substance use disorder that you can actually use with patients. You can talk to them. You can tell them that they actually meet the criteria for mild, moderate, or severe alcohol or substance use disorder. And you just I like using these words because I for one respect the researchers and scientists who came up with this kind of stuff, and it clinicalizes it and it takes judgment out of it when you use these words to help you describe what someone's going through, right? And you can kind of shine a light on, did you know that lots of people have substance use disorder and it's treatable? You can instill hope. Okay, next slide. This is more about, so what's baked into SBIRT is motivational interviewing. I'm going to whip through this slide as well because I don't consider myself to be an expert motivational interviewer. I'm still learning how to be a good motivational interviewer, but to remind you, some of the interaction techniques include open-ended questions, affirmations, which are really, over the years, I continue to look for and explore how to affirm people who are in tough times in their lives, right? Like, let's take, oftentimes we're dealing with people who are in really chaotic situations, unhoused situations, injecting drugs, and their lives are pretty bleak, right? So finding ways to affirm people in those situations may be at first difficult, but it is not impossible, right? When you get to know people and you express curiosity about them, you ask them about stuff, even stuff not about their drug use, right? Like, where'd you grow up? Where are you from? Who's in your family? Who do you love? What do you like to do? You know, like you can find connection points and you can say things like, wow, you've been through a lot. You're strong. You've been in recovery before, and that's amazing. You are resilient, right? You can find ways to affirm people, and that is an important part of motivational interviewing, to build people up. There's an awesome asynchronous course at psychwire.com from the founders of motivational interviewing that I would urge you to look into. It's relatively affordable. It's like $300 or something like that. And I've taken at least one of those courses, but it's from the inventors of motivational interviewing, who are much more eloquent about this topic than I am. So if you've never taken an MI course, I would urge you to. Next slide. But MI is an important part of SBIRT. Practically, if you've never done a lot of SBIRT, I love apps. There's a desktop app that patients can even use, but the Apple app that I link you to here is really cool, and it gives you the language and the steps one by one on the screen. It starts with these single question screens, and again, this is something that, you know, again, for generalist nurses, I find that we don't do enough of these recommended screening questions. We still are the old days of like, do you drink, smoke, or use drugs? No, great, next question, right? That's the extent of screening in the ER oftentimes, right? But as you work with patients, perhaps you're in an inpatient hospital setting, it's really important to phrase it differently, right? And give people the opportunity to actually talk about it. And it's important for us as providers to like care about these questions, to say, you know, like I read one time that like 20% of hospital admissions are related to alcohol use disorder. But I also don't think that 20% of our admissions, we're talking to people about their alcohol use disorder. Do you? I think we could do a lot better at it, right? Take the time. Like, is it okay? Because substance use affects people's health, I talk to everybody about substance use. Is it okay if I ask you some questions about that? We spend a little time talking about that. And I'm not talking about a half hour. I'm talking about 5 minutes. The question, when was the last time you had more than 4 drinks in one day, is a great single alcohol question, right? Because it really gets people thinking. You know, at times in my life, I would have answered yes to this, right? But I never was asked it, mind you. Like in any of my primary care visits as a young, relatively healthy alcohol user, I was never, no one ever asked me, like, have you ever drank more than 4 drinks in a day in a sitting? Because that can be potentially unhealthy. No one ever had the courage maybe, or the training to do it, and I think we should. So if people screen in with those single questions, we move on to the longer screenings. Again, I know you all are developed, and I don't want to bore you with going through every question of the audit and the CRAFT and the DAST. So we can jump to the next slide. But one thing that I really love about SBIRT and motivational interviewing in particular is asking permission. Is it okay if we continue to have this conversation? It's just so simple. It's polite. And if you forget to do it, the conversation may not go well. But if you remember to do it, almost always people say, sure, we'll keep going, right? But it's just so polite, and it's also evidence-based. Like if you are trying to talk to somebody who does not want to talk about this issue, you're not going to go anywhere. And in fact, you may damage the relationship by continuing the conversation. And that's what I also think is really cool about the research around motivational interviewing, is that if you start to plan for a patient before they're ready to plan, you're actually damaging the relationship, and you're taking steps backward. So please just don't do it. I give you permission. If people aren't ready to talk about this, respect them and say, well, thanks. You know, is there anything else I can do to help you stay safe? And that's where harm reduction plays a large role. This is the low risk drinking limits that you can share with people. We can jump to the next slide here. These are the audit questionnaire. I love using the audit because it's another way of being non-judgmental. I pull out my phone and I say, is it okay? So you answered yes to that first single screening question. Is it okay if we talk some more about alcohol? I like to use this screening tool that was developed by researchers. Is that okay? Pull up my phone, and then I just read these questions. it takes judgment out of it altogether. It's really great. Like, because if you have to come up with these questions on your own, I think it's an uncomfortable conversation. You know, you might say something that is like potentially judgmental. If you rely on just the screening tools and you just turn your head to the phone or a paper or whatever and just say, let's talk about this question, it works well. Next slide. 1250. The only comment I'll make here about is the drug abuse screening test. I hate the title of that. It hasn't been renamed, so I use different language as I go through this screener. I talk about drug use and I don't use the word abuse. Next slide. So once somebody has screened in, the next part of SBIRT is brief intervention. And brief intervention, there's a sort of a recipe for it. And it goes like this. You basically want to start by building rapport and, again, expressing curiosity about how somebody uses their substance. And you basically want to get to what are pros and cons, right? So that's sort of the first step of brief intervention is tell me what your life is like. I'm interested. What are the pros and cons of your substance use? And then the readiness ruler is a really kind of cool tool. Again, you don't have to take every aspect of this into your own practice, but it is a nice way of stimulating what we call change talk. And I do like to also talk to providers about this. I think a lot of times providers have cognitive dissonance. You know, you want somebody to stop using a harmful substance. So you feel like it's our duty to say, you must stop, right? But the science says that that doesn't work, so we really shouldn't be doing that, right? So in order to like help with that cognitive dissonance, I tell people it's okay to tell them that you wish you could tell them to stop and that it would work, right? But you also have to own it that doesn't work sometimes, right? So I often encourage my nursing students to say, if you feel like you need to, tell them, as your nurse, I really wish that we could get you to stop using this harmful substance altogether. But I know that that's really difficult sometimes and you have to be ready to do it. How ready, you know, considering what we've discussed, how ready are you to do something different about it? And you can sort of gauge them on this readiness ruler. And then the next part is if they fall in the middle, you ask them, well, oh, that's a pretty good number. It's a 5. Why is it not a 0? And what you're getting the person to do is telling you their own motivations to quit, because that's what motivational interviewing really, the takeaway is that people are motivated by their own inner will to change, not even good ideas from us, right? So what we have to do is kind of tweak and bring those own ideas out through engaging in talk. If somebody's not ready, if they're on the low end of the readiness ruler, again, going back to what I said earlier, if you start to push too hard when somebody's not ready, you may go backwards. So my approach when somebody is in the lower end of the readiness ruler is just to say, that's okay. Doesn't sound like you're ready. Let's talk about something else, or let's talk about this the next time, or how can I help you stay safe if you continue to use. Next slide. It's 12:54. I'm way behind, so I'll try to go quickly here. I just basically said all of what this slide says, how to sort of engage with people who are in the middle of the readiness ruler versus the lower end of the readiness ruler. The text in red here is harm reduction actually can occur at any stage, even if people aren't ready for treatment. So that's the beauty of harm reduction, is because you oftentimes, you know, again, thinking about what I've learned and unlearned is like, I used to think that like, if somebody's not ready, then there was nothing I could do. It's done. You know, come back next time. They often feel dismissed, but harm reduction is treatment. You can engage people in treatment even if they're not ready for treatment. Let's go to the next slide and we'll move on to harm reduction. I'm going to skip this video. I'll let you watch these on your own. There are some ways to intervene. And again, you don't have to do it all. Just be willing to talk to people about substance use. This is my slide where I believe harm reduction is the essence of nursing care. It is treatment. It is what we do for every other important health threat. And the science says that harm reduction saves lives. And there's a link to the harm reduction principles that you can read about if you haven't ever before. You can go to the next slide and we'll talk about practical, actual actions of harm reduction. The two big ones around opioids and injectable substances are naloxone saves lives. It should be everywhere. We should have low barrier, low threshold access to naloxone because it's such an important medicine to just keep people breathing. And then the graphic on the right is about syringe access. If you're hesitant about syringe access, please just let me just like summarize nearly 50 years of research that shows that it does nothing harmful. It does everything good. It is the gateway to all things good. Okay. When people have access to sterile syringes, they don't get infections. They get access to caring individuals who can point them towards wound care, towards treatment, towards basic health care. It's so important. It's so important. Does it quote unquote enable people to use drugs? No, the only thing it enables is health and safety. That's our mantra. Please read about syringe services if you have any questions about it. It's widely accepted to be a very safe public health intervention. There's a link to find syringe service programs in New Hampshire. Thankfully, there's a lot more than there used to be, and we're continuing to expand. So when you have a patient who injects drugs, please make sure they're connected to a syringe service program. Next slide. Anyone who is caring and looks at the picture on the right and doesn't think that everybody who has to inject a needle into their skin for whatever reason should be using the needle on the left, I think there's something wrong. Next slide. This is one of our resources that was developed by NHHRC. We provide stay safe tips. Nurses are great at this. I remind nurses, you know how to access veins. You know, don't be afraid to talk to people and tell them how to keep their veins safe, right? How to sterilize equipment, how to use antiseptic solution on the skin prior to injection, how to rotate your veins, how to go slow and be careful, how to always have naloxone available. Next slide. This is about naloxone. Naloxone is thankfully much more easy to access now than it was 10 years ago when, you know, I was one of the first prescribers in New Hampshire that was willing to prescribe third-party prescriptions. It was a nightmare. You know, family members who needed naloxone had to find John Burns, who would then come to me, and I would have to write hundreds of prescriptions to give them this life-saving medicine so they could potentially revive their loved one. Nowadays, thankfully, I'm a huge fan of free access to naloxone. You can get it at any of the doorways. You can get it at recovery community organizations, and you can get it at syringe service programs for free. You can also go into almost any pharmacy and purchase it if you have the funds to do so. But naloxone in and of itself does not save every life. You can't give naloxone to yourself. So it's really, 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 really important that we encourage people who use opioids to never use opioids and other drugs, right? Because now stimulants are often tainted with fentanyl. So it's really important that we encourage people to never use alone. There is a 1-800 service that will allow somebody to use their drug while on the phone with a caring person who, if the person doesn't respond in a certain amount of time, can send EMS to the house. The takeaway here, though, is like there's so many tragic stories of loved ones in my own life who know everything there is to know about naloxone and still die of overdose because they used alone. A lot of times that's related to stigma about recurrent use, and it's tragic. Every overdose is a preventable overdose. So next slide, I think, talks about some. Oh, this is another resource from NHHRC. It is a resource about having the conversation. It gives you some example words of what you can say to people who might be injecting substances. Tell me more about this wound. How are you able to get clean supplies? How do you stay safe? Do you have naloxone, etc.? Next slide. Thanks. I'm sorry, I'm running a little bit over time. I apologize. This last slide is talking about other current and future harm reduction solutions. As I was saying, naloxone in and of itself doesn't prevent an overdose if you're using alone. I think one of makes the most sense, overdose prevention centers or supervised consumption spaces is another potential tool that we should be using in the US to help save lives. Again, I didn't cover any of the stats here, but everybody knows 100,000 lives lost to overdose deaths in the US is embarrassing and tragic, because every single one of us, I'm sure, knows somebody who's died of an overdose, and it's heartbreaking. And overdose prevention centers are yet another tool that can actually save lives. They've worked in other countries. In the millions of injections in overdose prevention centers worldwide, guess how many deaths have happened? 0. 0 deaths in a supervised consumption facility compared to 100,000 deaths. Many of the people perhaps on the street in unhoused situations alone. It's terrifying. Boston has sort of a workaround. They operate what's called a SPOT, a supported place for observation, where they welcome anybody who has recently used substances to come in and be monitored. We could be doing more of that in New Hampshire, I think. It's really important to have access to drug checking so that people can have a better understanding of what's in their drug. In New Hampshire, fentanyl test strips are the only type of drug checking equipment that are currently legal, but that only tests for one contaminant. We should have a wider spread drug checking capability in this country. Other states do it. Hopefully we'll get there in New Hampshire. And then mobile van services. I love the idea of Dan and I have been in board meetings before, and I've talked about blowing up our whole healthcare system and starting fresh. And I think mobile services is one way of actually doing that, right? Many people, especially people who inject illegal drugs, do not feel comfortable within our systems. And I would love a system that brought healthcare, compassionate healthcare, to the person that needed it. It's really the definition of meeting people where they're at. Like, let's just bring everything right to you, okay? Let's bring you preventive healthcare. Let's bring you health screenings. Let's bring you medicine. Let's bring you syringes. Let's bring you naloxone, whatever it is you need to stay safe and alive, because I know you're somebody's loved one. I have loved ones out there who I wished could have had those services so they would still be with us. Next slide. Because we're over time, I won't force these questions, but I like to talk to people about, the likelihood of recovery from substance use disorder, and, especially in, with these sensationalized stories about fentanyl and its scourge and the opioid epidemic, and it often sometimes feels hopeless. But the reality is, and John Kelly, if he's talked to you before, will tell you this, that the recovery from substance use disorder is actually pretty good prognosis. We can go to the next slide, and that summarizes, really, it's the work of the Recovery Research Institute, which Dr. Kelly is in charge of. We can remain hopeful, and we can instill hope. We just got to keep people alive. The rates of relapse between substance use disorder and other chronic illnesses are actually favorable. 40 to 60% of people who have substance use disorder will achieve full remission. And even in the people who don't achieve full remission, we can keep them healthy. We can keep them alive. We can keep them free of, HIV and hepatitis C and even endocarditis. We can keep people free of it. Sarah Wakeman, on a podcast recently, said a really interesting thing about endocarditis. Endocarditis is not caused by fentanyl or methamphetamine. It is caused by unsterile injection of tainted, contaminated drugs. It's a failure of health policy. It is not a drug. It is not a substance problem. It's a policy problem, endocarditis. So we're all part of this. We need to continue to learn and unlearn and spread the word. I appreciate all that you do. I'm sorry I went over time, and I hope some of this was helpful.
Jason, can you hang for a minute in case
Yeah.
there's any questions? You can
Happy.
put it in the chat, or you can use your reaction button if there's any questions. Well, I had one. Is that okay if I ask one?
Yeah,
Jason?
please. Yeah.
Great. Or it was more of a comment, and I put it in the chat. Oftentimes,
Oh,
I think providers are scared to do the screening if they feel there is no resource if they answer yes, right? And so I know we've gotten much better about treatment, transitioning to recovery supports, you know, and I know docs have really been trained much more heavily. But how do we overcome that stigma of, like, don't ask the question if you don't want the answer because you don't have the resource?
Yeah. I mean, I think at a minimum, you do have a resource. It's called the doorway. You know what I mean? It's called the doorway or 211, right? Like, it's not perfect, right? Like, we all know that, but like, it's fairly easy to, or you know, like in that moment, I think, Melissa, like, and I've been there, honestly. You know what I mean? Like, I remember years ago when we worked together and you guys helped give us a list of all the treatment places in the state, and we would stock them in our ER, right? But before that, I was just like, I don't know, you know, but I still want to ask the questions so that if somebody's ready, then I, as the healthcare, there's lots of things I don't know as a healthcare provider, right? But if there's somebody who comes in with a differential diagnosis that I don't know the first thing about, if I've never treated, you know, whatever, some rheumatological condition, I can get online. I think that's my job. You know what I mean? It's like, I can find out what the next step is. But to answer the question about treatment in New Hampshire around substance use disorder, I think we have some basic, pretty good foundational resources like 211 and the doorway, and also, like, going back to my earlier comment, like, just asking the question is enough, right? It's the long game. We're playing a long game here with people, hopefully, if we can keep people alive, right? You're playing a long game. Like, ask the question, express concern, show curiosity, show caring, and then you'll figure it out together. Does that help at all?
Okay. Danny, did you want to do our closing comments?
Sure thing. Thank you, Melissa. And thank you all for joining us today for this COP. We appreciate your time, and we appreciate all the insights from Jason. Thank you so much. We want to mention, as we go over our slide here, if you'd like to explore additional resources or revisit today's conversation, you can visit nhtac.org. There you'll find a recording of today's session, previous COP recordings, and a variety of tools to support your work. Before you go, Paul dropped in the chat a link, and we can also you can also scan the QR to complete the evaluation. Your feedback helps us continue to improve these sessions to ensure they meet your needs. Please give us your feedback if you can scan the QR or use the link in the chat. After that, we want to thank you all again for being with us today. We look forward to seeing you at a future COP. Take care. Enjoy your afternoon. Thank you for coming.
Thanks, everybody. Thanks, Melissa, Dan,
Great to
Danny.
see you.
Nice to see you all. Take care.
Thank you, Jason. Thanks, everyone.
Thanks, Dan. Thanks,
Bye now.
Danny.
Thank you all.